Okay, we're going to go ahead and start. And as people sign in, I will make sure they get all checked in. So thank you so much, everyone, for being here today. If you didn't catch earlier, my name is Gage Woolley. I am the alumni relations person, essentially, for the College of Nursing. I'm so happy to be able to put on this webinar with the help of Lori Catalano. She's done this a couple times for us now, but we have her spotlighted as well. She's a great presenter, and I have a quick little bio about her. Right after that bio, I'm going to let her take the floor and just go ahead and present on this important topic. But just as a reminder, we are recording, so then we can put this online and people can view it later. Also, if you have any questions, you can put those in the chat. I will be able to bring those to Lori's attention. And then lastly, please make sure you're on mute during this time so there's no interruptions. With that being said, I'm really happy to introduce Lori today. So Lori has been a professor at the College of Nursing since 2011. Prior to that, she worked at a variety of acute care hospitals, specializing mostly in cardiac care. She received her BSN and MSN from UC, her law degree from Capital University, and her PhD in nursing from Indiana University. Her research interests include nursing education, legal issues surrounding nursing care, and advanced directives. She has been on the board of the local chapter of American Association for Critical Care Nurses and is active in both that association and in the Ohio League for Nursing. While not practicing law, she still stays current on legal and professional issues affecting the nursing practice. That being said, thank you so much, Lori, and the floor is yours.
Okay. Hi, everyone. So this presentation will take care of your Category A requirement for Ohio. We have almost 100 people here today. That's like twice as much as we usually have. I am including some of the basic stuff, but I will preview a little bit that we are going to talk about nursing negligence, and we are going to talk about redonda vot and what that means for us, because it does, it is, part of the Nurse Practice Act in Ohio as well. So we're gonna talk about a whole lot of stuff today. So as Gage was saying, I am faculty at the University of Cincinnati, and so I know a lot of you are here today from there as faculty members, and everybody else is hopefully an alumni. Please put your questions in the chat, like he said. Sometimes I can keep an eye on them, and sometimes he will bring them to my attention. So I'm going to go ahead and share my screen. And you should all be seeing my desktop.
That's correct, Lori.
Okay. And there we go. So Gage, are you going to enter people into the thing? I just saw people enter the waiting room. Okay, yep. Cool. All right. So Nursing Law Update 2023. I do these, if this is the first time you're coming to one of these, I do these every 2 years in the odd years that we are required to renew our license. So just as an FYI, in 2 years when you're looking for this, it'll be me again. So our learning objectives for today. I do want to note this is not legal advice. None of this is legal advice. So learning outcomes today, we are going to look at the standards of practice for RNs, LPNs, and a little bit of APRNs. And we're going to talk about those standards of practice. We're going to talk about scope of practice, and we're going to talk about violations of the Nurse Practice Act, looking at disciplinary actions that the Ohio Board of Nursing can do. We can also look at what happens when they become criminal offenses, and that's where we'll bring in some thoughts about redonda vot. First off, scope and standards of practice. So when we talk about scope of practice, that's what we can do as RNs. And the majority of these are independent. And I'm not going to read these to you, but as summary here, we do what we know of as nursing practice. So it is assessing people. It is assessing their health status, right? As nurses, we treat the patient. We don't treat the disease process. We treat the patient's response to the disease process. And it's one of the things that I tell my students all the time, that they need to focus on the patient's response, right? It doesn't really matter what disease they have. if they're responding a certain way to it. So we do all of our assessment, and the nursing process is actually codified in our Nurse Practice Act. So, when we learned that nursing process way back in nursing school, a long time ago for some of us, including me, we didn't realize that that is the law, that the law says we have to do that. So we plan our care, we execute those interventions. The only thing that is dependent in all of our actions is actually administering medications. So, all of our meds, all of our treatments that require orders, those are dependent actions, dependent on an advanced provider of some sort, whether that be an advanced practice nurse or a physician, or whoever else you're working for. All of the other stuff, though, it's all independent. And I like to tell people, if you have a patient who is admitted, who is immobile, a provider will write an order to turn and reposition every 2 hours. We don't do that because we have an order. We do that because that's an independent intervention of our own, and we would do it anyway. So little things like that, we don't need orders for those. That's within our independent scope of practice. Now, let's contrast that with LPN scope of practice. And I never used to really focus much on LPNs, but simply because most people who came to these were RNs working in acute care. However, we are seeing more and more LPNs in acute care. And also I felt that I was doing kind of a disservice to people who work other than in acute care. But we do see LPNs, and LPNs don't have any of that independent practice. And so you have to remember that as the RN supervisor for that LPN. They can do some contributions to the planning of care, but they can't actually plan the care. They can give meds. And in fact, last year, and this is a new thing, some of you may or may not be aware of it if you work with LPNs, but Ohio used to require them to be certified to give IV meds, and that certification requirement was actually taken away. Now, this doesn't really mean anything for an LPN who is licensed in Ohio, who receives their education in Ohio, because all Ohio LPNs receive a course in IV medications. That's not true in other states. And so with some of and that was something that that there was definitely some argument against this new law that said they don't have to be certified, because some of our LPNs may never have received training on IV medications. And so this is something that you as the supervising nurse need to make sure that you're aware of, because the rule is still, if they can do it, if they have the ability, they have the training, and they feel comfortable, and you feel comfortable having them do it, then they can give IV meds just like they can give the rest of them. Teaching, LPNs don't do teaching, but they can reinforce it. So we have to start it as an RN, and then it moves on and they reinforce it. Now, one of the things is that LPNs, when we assign care to an LPN, it's not called delegation, that's actually called assignment. We delegate to our PCAs, our unlicensed personnel, whether you call them a nurse aide or a patient care assistant or whatever. That's delegation. It's assignment when we have an LPN do it. Now, an LPN cannot directly delegate to a PCA unless the RN tells that LPN, yes, you can delegate these tasks. Now, in real life, we don't do a lot of specific delegation. Our PCAs will go in, they'll do our vitals, they'll do our baths and things like that. And that just happens automatically a lot of times. It's part of their job description and they know it. And it's something that we have to almost say, hey, don't do this today, I'm going to do it. And that's part of real life with the way our PCAs function, but understand that, the law does say that you have to specifically delegate and follow up. So some of the things to remember, and I mentioned this already, LPNs in Ohio automatically take that IV therapy course, and they don't have those independent functions that we do. Okay, they can only teach if the nurse tells them to teach. They can only delegate if the RN tells them to do so. they can gather data, but they can't form a care plan. So specifically with some of the things with IV meds, and these are going to come up more often in your acute care facilities and also in your LTACs. So IV skills are now considered a default ability, meaning that they got them in nursing school. And again, that begs the question of where did they go to nursing school? It is okay for them to do IV fluids, antibiotics, certain medications through a peripheral IV. You got to be careful if the patient has a central line of any type. They can run IV fluids and antibiotics through a central line if the line is already accessed. They can't change the caps. They can't change tubing. They can't access it for the first time. They can't put the flush in. So they can't, there are daily flushes for central lines, for example, where we change the caps and flush them out with saline. They can't do that. And so you've got to be super careful with stuff like that. The nurse has to be readily available. There is one little asterisk to that, and that is if it's a long-term care facility, that nurse can be available by phone rather than in person. One thing they are never allowed to do is TPN. And so you got to be careful with that. And for kids, LPNs aren't allowed to do anything except basically maintaining IV fluids. So they can hang new bags and things like that. But there's a lot of limitations when it comes to pediatrics with LPNs. So they can definitely give fluids, antibiotics, and they can give flushes in peripheral IVs. They can also start a peripheral IV. They can stop blood, but they can't give the blood. Okay. They also can't give TPN, like I said, and they can't give IV push medications. So think about your things like your vasopressors, for example. If you're pushing digoxin, for example, your LPNs aren't going to be able to do that. And in general, the only things they can initiate are fluids and antibiotics. Everything else the RN has to start with. And that's kind of the big thing that I feel like a lot of people don't understand. One of the other pieces, and actually I don't have this on the slide, is that an LPN can't take a telephone order. That has to be from an RN. And so as the RN, you may be asked to witness a telephone order or to call for a telephone order. This is the OBN's decision-making model, and this is for RNs and LPNs, and it's also kind of for PCAs as well. And I know this is really small. I just wanted to kind of show you the steps of it. And basically, when you are deciding whether or not you can have either a PCA or an LPN do a certain task, the first thing that you have to look at is whether you, as the RN, are allowed to do that task. And if you're not, then neither are they, okay? If it is within your scope of practice, then we move on and we look at the LPN or the PCA and we say, is it within their scope of practice? Is it something that they are allowed legally to do? We can't tell our PCAs to go administer medications, okay? That's not within their scope of practice. We can, however, tell the LPN to administer medications. That's a routine part of LPN practice, is going and administering medications. But we have to make sure that that LPN can demonstrate the knowledge and the ability to do that. All of our LPNs have been trained, they've been oriented. So that is going to be something that's going to be within their ability. Then you have to look at whether or not this is good for the patient. Does the patient maybe have extra assessments that need to be done? If so, then the RN probably has to be doing it, okay? And then finally, you as the RN have to be ultimately accountable. And if you cannot answer yes to all of those questions, then that's not something that you can do. So I got a question here real quick. Are LPNs allowed to take telephone orders in long-term care facilities? I believe I would have to check on that one. But telephone orders in general are not, they're not part of LPN scope of practice. And so I don't think that there is a I don't think there's anything different about long-term care facilities. The RNs are going to be taking the orders and then updating them. Now an RN can sign off on an LPN's order, but that RN has to also hear the order given. So, all right. So standards of practice. So these are things that we have to do. We have a duty to clarify orders. We have a duty to maintain confidentiality. We have a duty to display our title or initials. That's when, like, gosh, it was probably 25 years ago when we all got the little tags that said RN on them. That's because it's state law. It's part of the Nurse Practice Act that says you have to have a tag that says you're an RN. Duty to promote a safe environment. This doesn't just mean physical safety. It also means medication safety. Okay, and we're going to talk about medication safety when we talk about redondavat. Duty to maintain professional boundaries. Don't friend your patients on Facebook. This becomes an issue with older patients at Children's Hospital and younger nurses. I have heard from different people talking about it, that patients on the adolescent floor, they get very attached to their younger nurses and they want to make friends with them on Facebook. And it has come to me in clinical a couple of times where if the students have younger patients that they are requesting, the patients are asking them to be friends on Facebook. So, okay, thanks, Keely. So they can accept telephone orders now. Okay. An RN still has to sign them off in the computer and do the official authorization. So how do we promote this client safety? And they've actually codified this in the administration code, the Ohio Administration Code, Administrative Code, which is the Nurse Practice Act. We have to display our nurse title. We have to delegate within the boundaries of the law. We have to timely and accurately document our nursing interventions. And we know that sometimes that is an issue. Okay, that really is an issue sometimes. Avoiding falsification of the record, promoting a safe environment, that's kind of general, establishing our professional boundaries. We've got our privacy, confidentiality rules, refraining from physical, mental, or emotional abuse, stealing, sexual conduct with a client. All of these things happened. That is why they had to put them in the Nurse Practice Act. Okay. So here's an example of good documentation, and why it's so important. So, and this is an older scenario, but it's perfect for this and why documentation is so important. Jessica was a little girl. She's 2 years old. She was brought into the ER for fever and dehydration. And the ED nurse does several neuro assessments over the course of the evening, and they're all normal. All of this little baby's neuro assessments are totally fine. They give her fluids. Later, she's taking fluids well, her fever's gone. 2 days later, she comes back with the same symptoms. Again, the nurse is documenting that her neuro status is totally within normal limits the whole time. She stays overnight this time. She gets IV fluids again. She is sent home. A week later, she goes unresponsive. She ends up having a brain tumor. They resect it, but she has permanent disabilities. Family sues, and it turns out that the emergency room doc never documented a neuro exam, but the nurse did. And so they were able to rely on the nursing assessments to say there was no indication here that anything neurologic was going on with this baby when they had her in the ER before. It was simply dehydration and fever. There wasn't anything else going on. And so that's something that's it just kind of highlights the importance of why we need to make sure that our documentation is very precise. Okay. So complaints and violations. Anybody can file a complaint, and they can file a complaint about anything. Okay. It could be that the nurses never fed me, and maybe that was because you were NPO. And that's why we didn't feed you. So, and people do, people complain that they didn't get fed while they were at the hospital, and that's because maybe they were NPO, or it can be a real complaint. And OBN investigates all of those complaints to determine whether the Nurse Practice Act was violated. They do, if it's a minor, first of all, if it's not a violation, it's not a violation. If it is a violation, but it's a minor violation, OBN actually has the discretion to act on them. So they don't act on all violations of the Nurse Practice Act. But remember that the Board of Nursing, their goal is not to protect us as the nurse. Their goal is to protect the public. So they will really focus on these violations, and they're going to take them very, very seriously because they want to protect the public. They can refer it to other agencies, and that includes the Attorney General for some criminal actions. So they can take disciplinary action on their own, and it depends on the severity of the violation. And action is taking on roughly a fourth to a third of all of the complaints. And this action could just be, hey, take some CEs, okay? It could be as much as permanent revocation of your license, prohibited from ever practicing nursing care, okay? And it could be anything in between. You could have it suspended for a certain amount of time. You could have it, you could have it suspended and then placed on probation. You might have certain restrictions. You might have to have a public reprimand. You might be imposed a fine. Or they can send it over to the state attorney general, and you can have criminal charges brought against you. So there's lots of things that constitute a violation, these next few slides. So actions by another state for any reason other than failure to renew, that's a violation. So if I violate I have a Kentucky license because I live in Kentucky. If I violate my Kentucky, if I do something that is a violation in Kentucky and Kentucky takes action against me, Ohio can too, because Ohio doesn't want me practicing, because it's still me, right? It doesn't matter that it was in another state. It's still me that violated the Nurse Practice Act. And they don't want me in there violating the Nurse Practice Act in Ohio either. And so that is actually a violation. And that's one of the things, these are some of these first few here are the ones that we have to answer. Remember the questions that you have to answer when you renew? This is what they're asking about. Engaging in practice while you're suspended or expired, that is a violation. I remember when I was in orientation as a brand new nurse, my preceptor, she accidentally let her license expire. And so there was one day I showed up and they said, she cannot be your preceptor today. And she spent the entire day in the office trying to get her nursing license renewed. And so that was a huge thing for her. Any kind of guilty pleas or a conviction of a misdemeanor that is committed in the course of nursing practice. So if it's a misdemeanor, but not related to you being a nurse, then it's okay. But if it's a felony, it doesn't matter that it didn't relate to your nursing practice. It's still a violation. Drug convictions, failure to maintain confidentiality. HIPAA is extremely important. All of that is going to be a violation. Self-administration of drugs that are not prescription. Impaired practice due to drugs and alcohol. And we're going to talk about a situation where a nurse had impaired practice, not from drugs or alcohol, but from lack of sleep. And that was a violation. That was negligence too. Habitual or excessive use of drugs or alcohol that impair their ability to practice. Impaired practice because of physical or mental impairment. That was that lack of sleep. Adjudication of mental illness or incompetence, practicing outside your scope of practice. So if you are an RN and you are writing orders, even though you're not an advanced practice nurse, that's outside your scope of practice. Assaulting a patient, depriving them of ways of summoning help. You can't put somebody in restraints if they, take away their call light. You can't take away their call light in general because that deprives them of a way of summoning help. Trying to get money from them or stealing from them. Failure to practice, and this is the important here, failure to practice according to standards of safe care. That's huge right there. or helping the unlicensed practice of nursing. It doesn't have to be you doing it. And then finally, failure to keep professional boundaries, assisting suicide or prescribing drugs to induce an abortion. And then our catch-all, which is violations of the Nurse Practice Act or any of its rules. So they kind of just added that on at the end there. So let's talk about the common ones. And these are, if you talk to the Board of Nursing, these are the complaints that they get the most, that really are violations. Okay, they're not just my nurse didn't feed me, and even though I wasn't allowed to eat. These are your big ones. So these are not in order. These are just the top ones that they see. Failure to administer CPR. Now, these complaints usually come in places other than a hospital. So anything that's not acute care. And a lot of times here, you're looking at more limited resources. So the important thing is, if you work somewhere in any facility that isn't an acute care facility, know your procedures, know where all of your resuscitative equipment is. You need to know, do you have a crash cart? And some, if we're talking outpatient facilities, they might not have a crash cart. They might just have an AED, for example. And the case study here that's happened, and this is a true story. It came from the Board of Nursing. This was a complaint that was found to be a violation of the Nurse Practice Act. So you have a nurse in a long-term care facility here, and they have a patient. They're working a 3 to 11 shift, and they have a patient who has complaints of shortness of breath at about 5 o'clock, 5:30, and the nurse gives them a nebulizer. So they give them their albuterol nebulizer. Patient looks okay, and so the nurse leaves the room and doesn't come back. Takes their dinner break at 7, from 7 to 7:30. At 7:30, coming back from dinner, they notice that the patient's call light is on, and thinks, okay, I'm going to check on my patient when I'm passing meds, because I'm getting ready to pass meds now. At 8:30, so now it's been 3 hours since that nurse gave the nebulizer treatment. At 8:30, the PCA comes and finds the nurse and says, this patient, she's unresponsive. So this nurse is actually so they find her in the med room, right? They find the nurse in the med room, and the nurse is getting medications out of the med room. So this nurse finishes getting the meds out of the med room, which I was like, whoa, that's where I kind of was like, yeah, that's definitely a violation. And so the nurse finishes getting the meds out and then goes down to the patient's room. Patient doesn't have a pulse. Okay. The nurse says, oh, well, I don't know if my patient is a DNR. And so they go to the nurse's station to look it up, and sees that the patient is a full code. So they call a code and overhead, okay, on the intercom system, so the nurse sees the PCAs go into the room, and this nurse assumes that the PCAs are going to start CPR. And so this nurse goes and she grabs the crash cart, okay, and then takes it down to the room where the PCAs are standing there. And this nurse is like, oh, why didn't you start CPR? And the PCA said, I didn't know what I was supposed to do. This is my first code. Neither one of them knew what to do. This patient did not, they did not survive. This patient did not survive. And so that's a true example of something that happened. But it's one of a long line of complaints that the board said that they get when CPR is not initiated, at least not in a timely manner. So there's lots of things that nurse did wrong. The nurse didn't reassess after giving the albuterol, the breathing treatment, between taking their dinner break. They didn't go and answer the call light when they saw it after the dinner break. They didn't go and immediately check on the patient when the PCA said the patient was unresponsive. They didn't start CPR immediately. And here's the kicker. If you don't know whether or not your patient is the DNR, you assume that they are not a DNR, they are a full code. That is, every board of nursing will tell you that. You assume they are a full code until you know otherwise. And so that nurse needed to start CPR at that point and have somebody else go look it up. That's the rule. All right. So another one is failure to administer meds, failure to do treatments. And the Board of Nursing calls this a practice drift. I had never heard of this term before. I've always heard it as a workaround. And these are things that you do that are not necessarily bad, although some of them are, and we're going to talk about one of them. But things that you do to make your job go faster because you're so incredibly busy and overwhelmed. Often the cause of this is what we call pre-documentation. Now, pre-documentation is a lot harder now because of electronic MARs, okay? But there are still some places that still document on paper when we're talking about long-term care. And it is still possible to pre-document even with an electronic MAR. And we're going to talk about that here. Wound care also is something that often gets missed. And when we're talking about meds that get missed, it's usually, according to the Board of Nursing, it was the usual things are daily meds in long-term care facilities because they get a whole bunch of residents' meds together, they sign them all out, and then they go and they deliver them to the residents. So this is an example of where electronic documentation did exist and the nurse still pre-documented. So the nurse has a patient with pneumonia, and this patient had 2 IV antibiotics that were supposed to start. Patients also ordered to get IV fluids and some handheld nebulizer. So the nurse scans the meds, gets them from pharmacy, scans the meds, goes in, and did they scan the patient? Apparently not. Apparently they did not scan the patient. Goes in, starts to hang it, but the patient's IV is bad. And so the nurse who's giving the meds, who has already scanned them out, calls the charge nurse to say, can you put a new IV fluid in and restart, or IV in and restart those IV fluids? And so that charge nurse did put a new IV in, restarted the IV fluids, but nothing ever happened with the antibiotics. And the patient's nurse had pre-documented the meds, so they were signed off. Next day, she has the same patient, goes to scan the meds, and apparently does the same thing where, again, the nurse doesn't scan the patient. Patient's actually an X-ray. And it's like the perfect storm, right? Too many things happening. Basically the same thing happened. So this is 2 days in a row that patient did not get their meds. And when they were reviewing it, they actually found the bags of antibiotics. They weren't even spiked. They had been signed off, but they weren't spiked. And so it was very clear that those meds did not get given. So in that pre-documentation happens in long-term care facilities if they're still on paper. Here's a big one: sleeping on duty. Interestingly enough, the board said that this is usually reported by other nurses, not families. So they've done studies that have said anything longer than an 8-hour shift, your mind does not, you're not as with it. Okay. You're not as alert. Even a 12-hour shift, there is more of a difference between an 8-hour shift and a 12-hour shift than between a 12-hour shift and a 16-hour shift. That actually really surprised me. I thought the big difference would be between 12 and 16, but it's not. It's between 8 and 12. They've also looked at hours per week and said more than 60 hours per week should not happen. More mistakes happen. Nurses get drowsy. And this can be an issue when, everybody knows that people are taking more and more patients right now. Nurses are getting mandated right now. So we have mandatory shifts. We have on-call shifts where you're going to get called in. We have nurses working multiple jobs. And it is a violation of the Nurse Practice Act to work while you are impaired. It doesn't have to be that you had a couple of drinks at dinner and that got called in. it could be sleep deprivation. Maybe you're on call for night shift, but have been up since 6 a.m. That it is a nurse, it's a violation of the Nurse Practice Act to work. So in this case, the case study that the Board of Nursing felt was really the person that I talked to. This is the one that he remembered. He remembered a home care nurse that was taking care of a baby. This baby was 2 months old. They were at home, but they had a trach and they were on a ventilator. This home care nurse is supposed to watch the baby overnight, and they fell asleep, and the baby's heart rate dropped. So they were on a continuous heart monitor, and the home care nurse did not wake up to the low heart rate alarm. But somebody in the next room, I believe the baby was in foster care actually, and somebody in the next room heard the heart rate alarm and came in and tried for woke the baby up, so the baby's heart rate came back up, but tried for half an hour to get the nurse awake. And this nurse had missed tube feedings. I mean, this nurse had basically been asleep for a few hours. Turns out this nurse was working 2 jobs. They had a home care shift during the day, and then they had another home care shift at night, and they were only taking a few hour nap in between. And so that was what the guy at the Board of Nursing that I was talking to, he said that one really stood out to him, because the baby was fine, but I don't remember if it was a boy or a girl, but they were 2 months old. And so that was, he said, yeah, we really sat up and took notice of that. So, failure to assess. And a lot of times here, this comes out when you miss those early warning signs. And this was, that's why we assess. We are at the patient's bedside. We can see those really, really minute changes, right? And so here, there was a situation where a nurse helped a patient to the bathroom, and he sees a little bit of blood on the toilet seat after this woman goes to the bathroom, and lady feels fine. He takes vitals, she's fine. And apparently then throughout the day, she has bloody stools throughout the day. And the PCA tells the nurse each time that the patient is having bloody stools. This nurse was busy with another patient, and he didn't go and assess her. He did get the charge nurse to call the doc and got an H&H order. But the nurse never followed up on the results. Turns out those results definitely showed a drop. And when he finally followed up on the results, he went in to check on the patient, and the patient is in bed in a pool of blood. When they looked back at the PCA documentation, this patient had over a liter of bloody output of bloody stools throughout the day. Actually, it was only even half a shift. And that nurse had not followed up on any of that. And so that was a huge deal there. But I'm sure that, all of us can think of times that, something, that things didn't get caught because nurses didn't assess. Finally, failure to make home visits. So our home healthcare nurses, some of you may be home healthcare nurses, they're overwhelmed too. It's not just acute care nurses. And this is keeping up with your schedule. You've got too many patients on your schedule, right? You're running behind because maybe a patient takes longer than usual, and you don't get in to see a particular patient. Okay. And the example that he had of this one, he said, this is just he told me it was just a recent one, but this was actually a nurse who reported it, because they were the follow-up nurse. So one nurse was supposed to do dressing changes twice a week on this patient, and he had some real bad wounds on his legs. And the first change of the week, no problem, does the dressing changes, and signs their initials just like we're supposed to do, right? And the next time when they go in the next day to do the second set, because it's twice a week, there's no supplies at the patient's house. Okay. So the nurse has to go get the supplies. But this nurse decides, well, I'm going to see my other patients on the way. Well, they never went back to do the dressing change. Now, this is another thing of pre-documentation, because they had documented that they did the dressing change and then found out that they didn't have any of the supplies. So the following week, a different nurse was there. And when that nurse got there, they realized that that dressing had not been changed for a week. And so, because it still had the date and initials on it. And so apparently, this was a consistent thing for this nurse, and that's why it finally got reported to the board of nursing. So, but those are your top ones. These are why people report to the board of nursing. All of these are violations of the Nurse Practice Act. Whether or not any of them rise to the patient who died, that would absolutely be something that was sent to the Attorney General. Okay. And because that's negligence. So let's talk about Redondavat. We all know who Redondavat was. We probably all followed it. So basically what happened, Redonda needed to give some sedation to a patient to have a scan. This patient was getting better. They were doing much better, but she needed to be sedated for a scan, and they were going to give her a little bit of Versed. And so she went to the Pyxis, and this was a floor that that routinely is at Vanderbilt, but there were so many issues with the Pyxis at Vanderbilt at the time that they routinely overrode orders, overrode the Pyxis to get it. And so she went in, she looked at the patient's profile, the Versed is not ordered. So she goes to the overrides and she types in VE. Well, the Pyxis is organized by generic names, not brand names. And so VE brought up Vercuronium, not Versed. Okay. And so she grabs it and she injects the patient. Vercuronium is a paralytic. So the patient couldn't breathe and the patient died by the time they got her. And so, there were so many systemic errors that happened. There are so many systemic pieces to that. The fact that they were routinely overriding them, the fact that all of our nurses are overworked these days. I will say though that she missed a lot of warnings. We as nurses and me as an educator, you got to do your medication rights, right? And one of the things is, do you have the right medication? This medication had a red cap on it that said warning, paralytic. And so there were a lot of pieces, a lot of pieces that she missed in here. Now, do I agree that she definitely violated the Nurse Practice Act, and she was definitely I would say she was even negligent here. Do I agree with what happened? Absolutely not. I don't think it should have ever gone to that, because it ruins our whole culture about med errors and how we work with system errors. So the legal background of this case, though, is that Tennessee Tennessee charged her with two things. Okay, they charged, and you can do this. You can charge them with two different things, and then basically the jury decides what, or you can say, if you don't think that she was guilty of reckless homicide, then you can find her guilty of negligent homicide. Okay, and so in this case, she was charged with reckless homicide. The jury convicted her of negligent homicide. And so negligent homicide in Tennessee is that you have to have negligence that results in a death. Okay. And so negligence is if a reasonable nurse in a similar situation would have appreciated that risk, it wouldn't have happened if a reasonable nurse in that situation had been there. And so, for example, with all of those violations in the Nurse Practice Act that we just talked about, those those all gave rise to negligence. Now, whether or not the nurses were sued, because you have to have harm. Okay, you have to have harm to actually sue someone for negligence. Now, some of them didn't actually have any harm. Now, the woman who died, absolutely. Okay. Tennessee, though, have a criminal negligence statute, and a lot of states do have a criminal negligent a negligent homicide statute. But Ohio's, and this is one of the things that's important here, Ohio's, it's very specific. Okay. And it has to basically be, you were being negligent with a gun or some kind of other weapon like a grenade that results in the death of somebody. So it is Ohio's negligent homicide statute. Nursing negligence, nursing malpractice would never give rise to a negligent homicide in Ohio, because it just doesn't fit the statute. Now, it doesn't mean that they can't change it, but that's one of the differences between us and Tennessee. So my issue with this is that we have this, what we call that just culture, right? That there are system failings, and we as individuals don't have any control over these system failures. The fact that they routinely had to override these meds. And, that was the big one. And she, as an individual, shouldn't be held accountable for that. Now, did she do stuff that violated the Nurse Practice Act and was negligent? Absolutely, she did. Okay. But to take it beyond the negligence and make it criminal, that's where everybody's freaking out. Okay. So this just culture environment has been in place for a really long time, ever since we said, med errors have got to stop, and med errors are often the fault of multiple things. And that's the system issue. Okay. So, and think about it at your facilities. Do you have to override? And how often do you have to override? What are your emergency medication overrides? Are they truly emergency medications, or are they any medication? So it really should only be emergency medications. Understaffing is huge. She had floated to a unit. Increased stress levels that is a system problem. The increased stress levels on our nurses, it's absolutely a system problem. And so all of those are things that play a very large role in this. So some of the position statements that came out after her, the American Nursing, the ANA, they said they were deeply distressed by the verdict, because they feel like it's going to criminalize the honest reporting of mistakes, and it's going to decrease the amount of mistakes that we actually that we report. The punitive approach to healthcare errors drives problems into the shadows. These are from like AACN, from the American Nurses Association, from the American Hospitals Association, from the Institute of Healthcare Improvement. They all agree. So they said that this case has placed patient safety at risk. It has further demoralized an already exhausted and overworked nursing workforce, and it has a chilling effect on the culture of safety in healthcare. Said that this verdict was harmful to nurses and all medical professionals, and that overall it makes our patients less safe. So did she violate the Nurse Practice Act? Absolutely, she did. Would she have violated it in Ohio as well? Yeah, she would have. If this case had happened in Ohio, it absolutely would be a violation of the Nurse Practice Act, because of the patient safety requirement. She did not guarantee, or she did not do patient safety. She clearly did something that, a reasonable nurse would have caught. Would it have given rise to negligent homicide in Ohio? No, because that's not how our statute reads. So it wouldn't have happened there. But it is a very slippery slope. And I feel like there is still going to be there's going to be an issue. We're going to see fewer errors reported. And then are we lowering the bar for criminal charges here? You know, she lost her license, which I don't know what would have happened in Ohio, whether she would have lost her license or been suspended for a period of time. And, you know, that kind of depends on the board. But, you know, in Ohio, she wouldn't have had criminal charges brought against her. So reporting errors, absolutely still report them. Address the system issues, be extra careful if the same situation happens to you, if you're having to override stuff, because a lot of nurses are saying it could have been me. It could have been me in that situation. So that's, you know, and that's the biggest thing. And that's why it all kind of hit us, right? So I see a question here. Can a judge override a jury verdict? Yep. The judge can override a jury verdict. That's pretty much the case everywhere, that a judge can override a jury verdict. But I'll take some questions. I wanted to include Redonda Vaught in there, but I wanted to make sure that we did it based on the Ohio Nurse Practice Act. So, all right. I got about 10 minutes for questions. You can put them in the chat.
I have a question.
Yep.
This is Rachel Bridges. So in light of thinking about a just culture and obviously wanting to not penalize people for system errors, what responsibility does a facility have for nurses who are sleep deprived, but hospital systems don't provide adequate maternity leave?
Wow, that's a big question. You know, that's interesting because we really don't have anything in place that says that the hospitals have to do that. We've known that for years, right? The hospitals are not mandated to do any of that. You know, you don't have, I mean, really the entire country doesn't have a very good maternity leave policy, right? But hospitals are not responsible there. It's interesting that hospitals they can mandate you to stay up to, they can mandate you to stay up to 16 hours. They only have to, it's been a while since I checked on this, but they only have to give you a 4-hour break in between shifts. That was the case. I don't think that that's changed, but they only have to give you a 4-hour break in between shifts. And so that's kind of scary. I worked with nurses who used to work 16 hours back to back. And that just is crazy to me. Absolutely crazy.
Yeah. As a mom of young kids, you know, who don't sleep through the night, I'm like, every nurse I know who has a child under 1 is probably operating sleep deprived.
Absolutely.
So it just, the way you presented it sparked my question.
Yeah.
So thank you.
Absolutely. Absolutely. So it's like, what do? Do you call in sick to work, or do you work sleep deprived? Are there limits on hours spent on in-house call shifts? I actually don't know that. I don't know. I'm not familiar with in-house call shifts. So statute of limitations depend on that depends on what the incident is. In general, you have to provide notice within a year. There's a case locally where a nurse working overtime died in an auto accident on the way home. I remember her. She fell asleep at the wheel, and that was it. Yeah, absolutely. And it's terrible, but it's happened more than once. And it's people who are working crazy long hours, like 16-hour shifts, or working night shift after being awake all day. Yeah, I remember that case. I remember more than one of those cases. Does the APRN need a DEA license if not prescribing medications but working as a CNS? No, You don't need a, no, you can work as if you're not prescribing medications, you don't need your DEA license. You don't need your, because I can work as a CNS. I am a CNS. I can work as a CNS, but I never took the courses necessary to prescribe, and that's okay.
Are there any other questions for Lori? Okay, it doesn't look like there's any other questions, Lori. Thank you so much for presenting this valuable information too. Yes, looks like very informative as always. Yeah, lots of comments.
I put my email in the address or in the chat. So
next steps for this are going to be with me. So if y'all have any questions about the CE certificate, you can please reach out to me. You all have my email. I will be sending that in the next 5 to 10 business days. There are a lot that I create all the certificates myself. So please bear with me as I get those all out to you. I will also send out an evaluation for this. If you could please fill that out for me, that will be able to give us some topics to, think about in the future, and then also give Lori any feedback about how she can make the presentation even better than it already is, because it's already pretty great. So, like I said, if you have any questions, please feel free to reach out to me regarding CEUs. Any questions about the presentation, please reach out to Lori. Lori, one final question for you. Will the presentation be made available? Can I include that as an attachment for folks?
Oh, sure. I can send it to you.
Yeah, that'd be great. So then I can at least folks can take a look at the PowerPoint again if they have any questions. I'll also include Lori's contact information there.
Great. There's a question about the CEs. You'll send them, right?
Yep, I will send those out. The CEU certificate will be out in the next 5 to 10 business days to your email inbox. If you do not get that, please reach out to me. I would be the one to make sure that gets done correctly. I'll cross-reference all of our information we get on the back end from Zoom and go from there. So any final questions?
Yeah, I do. Lori, I'm thinking about the cases you mentioned, and nurses really kind of extending themselves in terms of working beyond what they know is the Nurse Practice Act because they want to keep their jobs. Mm-hmm. Has the Board of Nursing ever sued an employer for insisting that nurses violate the Nurse Practice Act in terms of hours worked and that have led to a nurse making a mistake? Do you understand what I'm saying?
I do understand.
Who advocates for us?
Yeah, I will tell you that the Board of Nursing does not advocate for us. The Board of Nursing advocates for the patients. Yeah, and so as far as I'm aware, the Board of Nursing has never sued. The Board of Nursing has they've never sued hospitals. It really is it's nurse advocacy groups. So things like the American Nurses Association, who are advocating for the nurses, the the ONA advocating for nurses and insisting on better working conditions. That's really who's doing it. But they're not coming at the Board of Nursing. They're going to the legislatures and saying, we need this to change, that this is not, that it's not safe. And eventually it becomes unsafe for patients, but sometimes hospitals don't see the connection there. It surprises me that they don't see the connection there. So absolutely.
Okay, great, thanks.
Yeah, absolutely. Maureen, Gage, can we send out the link also in the email that you send out? I'll send the link for the actual PIDA. Emailed me or text me. We can send the link to actually the OBN for the Ohio Administrative Code, and it has the APRN standards of practice in it as well. So I can send that link out.
Yeah, if you send it to me, I'll make sure to include it.
Okay. All righty, cool.
Well, thank you so much, everyone. Have a wonderful day. And like I said, any questions for me, CEUs, anything about the presentation, that'd be for Lori. Thanks, everyone.
Thank you.
Bye.
Thank you.